Okay, so let's begin. Today we are going to cover the very high yield topics. The one is acid-base balance and the other one is pedigree analysis. So basically, these two topics, they covers your knowledge area from biochemistry and genetics as well. But in your exam, the mostly question you might get are like the more sort of data interpretation questions. For example, you will get the ABGs of a patient, and then you need to interpret that your findings, like what that particular ABGs talks about any patient. On the other hand, same goes with the pedigree analysis. Yes, indeed, it is the topic from genetics, but in your exam, they mainly ask questions in terms of data interpretation. So that's why these two topics are a bit tricky, and you need to have good concepts regarding these two topics. Okay, so let's begin from the pedigree analysis. And honestly, it is one of the easiest topic from genetics. If you once you understand the logics and if you know the criteria, like how a particular condition runs in the family, then you will never forget this topic. So what is this all about? Basically, pedigree analysis is in simple words, it's a genetic history of a family. It was developed to understand the inheritance of genes from parents to the offspring. It was developed as a chart that can represent a family tree along with the family members and their genetic traits, respectively. To simplify this topic, since we cannot cover all the genetics, anyhow, we need to know what are the common genetic disorders. And one thing I want to clear here is that the chromosomal disorders and the genetic disorders, these two things are different. I have seen many students who think that the chromosomal abnormalities or disorders or genetic disorders, they are the same thing. But no, genetic disorders are something else and chromosomal disorders are something else. So for now, in terms of pedigree analysis, we mainly see the trend of genetic disorders. So classically, it consists of three types. The one is autosomal, other one is sex-linked, and the third one is mitochondrial. The autosomal one is further divided into autosomal dominant and recessive, and same goes with sex-linked, that is X-linked dominant and X-linked recessive. Simply, the autosomal dominant conditions, they inherited, they mostly presents a structural problem in the offspring. Whereas in the autosomal recessive conditions, they tend to cause metabolic or enzyme defects. For example, this information is useful if by any chance you cannot memorize all the health conditions or all the genetic disorders of autosomal dominant category or maybe recessive category. But this would give you a hint if that particular condition has to do something with the structural problem, that is most likely be autosomal dominant. In the condition which has to do something, the disturbance with metabolic or enzyme defects, then that could be autosomal recessive. So it gives you a rough idea, and that would help to go and pick the right answer. Okay, so I just simplified all the genetic conditions. One by one, we will discuss everything. Let's begin from the autosomal dominant. I made a rule for the autosomal dominant inheritance. You need to keep this rule in your mind. That is, it is 50-50 rule. That means 50% would be affected and 50% would be normal. And for the dominant conditions, there would be no carrier state. Here's the list. This one. These are the disorders which follows the autosomal dominant pattern. And for all of these conditions, for all of these disorders, the rule would be similar. That is 50-50 rule. So in your exam, if you need to interpret any pedigree, and if you can find out the right answer in both ways. One way is that if you know the pattern, or otherwise, if you don't know, if by any chance, if you cannot interpret the pedigree, but yes, if you know that condition, if you are familiar that it falls under the category of autosomal dominant or inheritance or the recessive disorder, you can easily, even if you are not able to interpret pedigree, but still you can go, you can find your right answer. So 50-50 rule, uh, that means, let's take an example. Let me choose Ehlers-Danlos syndrome. So in this condition, for example, in your exam, you will get a SPA in which they have mentioned about Ehlers-Danlos syndrome. So now apply this 50-50 rule here. That means the half of the offspring would be affected and 50% would be normal. That's it. So this one is the easiest. It appears in every generation. That means it has a vertical pattern of transmission. Both males and females are equally affected. Since it is an autosomal related genetic disorder, so it has nothing to do with the gender, or it is not gender specific. So it can equally affect males and equally affect females. An affected person usually has at least one affected parent. Unaffected individuals do not pass on the trait. So this is very simple. That means what they are trying to say, since there is no carrier state and only one affected gene is enough to cause the illness. So again, the rule is justified that half of the individual would have the disease and half of the individual would be absolutely normal. And I'm repeating this again, there would be no carrier state in autosomal dominant pattern. Here you can see in this pedigree, it has shown that only one affected gene was enough to cause the illness. So this is, let's take an example again of Ehlers-Danlos syndrome. So it has successfully passed on to the next generation, and half are normal and half are affected. And it is also appears in the next generation. So there is no skipped generation in this condition. Next is autosomal recessive. So the rule to remember for autosomal recessive is 25, 50, and 25%. What does that rule mean? That 25% would be normal, 50% would be carrier, and 25% would be affected. If you remember these rules, you can easily apply these rules on any interpretation and you can find out your answer. Since it is recessive, so that's why we have a carrier state here. It often skips generation. Both males and females are equally affected. Why? The answer is again, the answer is same, that it follows an autosomal pattern. So autosomal has nothing to do with the gender. It is not gender specific. So both males and females are equally affected. Affected individuals can have an affected carrier parent. And these are the conditions which follow autosomal recessive pattern. If we look at this pedigree, here you can see both the parents are carriers. And now if we look at their offsprings, let's calculate. We have 50% carriers, 25% affected, and 25% normal, which successfully justifies overrule. Okay, in our MRCD1 exam, there are many questions from the pedigree interpretation from cystic fibrosis and also from hemophilia. So make your mind, most likely if you encounter a question from autosomal recessive pattern, that could be cystic fibrosis scenario. Okay, next, moving on to the next, we have X-linked dominant. Okay, before I explain you X-linked dominant, I will explain you X-linked recessive so that it would become easier for you to understand this. So this one is X-linked recessive. Now, this also has a rule, which is 25, 25, and 50 rule. That means 25% affected, 25% carrier, and 50% normal. Okay, here we can see the pedigree. This one follows the X-linked recessive pattern, and let's take an example of hemophilia. And when we look at the offsprings, we can easily appreciate that that unaffected son and unaffected daughter, that means 50% are normal, which justifies our rule. And then we have one carrier daughter and one affected son, that means 25% are affected and 25% are carrier. But here is some exception. Since it is X-linked genetic disorders, and now this is the point where we need to consider the genders, because X-linked disorders or conditions, they are gender specific. So one extra point I would like to add here: if in your question they are talking, if they are asking generally about the X-linked recessive pattern, then yes, the rule is valid. You simply go and assess 25, 25, and 50. The other way of the question in your exam, they might give you the findings in your question that uh, that 25% or which is equivalent to the one offspring, that one offspring is carrier and one offspring is normal. Two offsprings are normal, one is carrier and one is affected. So please pick one out, that what pattern is this for the mode of inheritance. So in that case, you can interpret like that. 1 equals to 25%. That means one is affected and another one is equal to 25%, which is carrier, and the two offsprings are normal, that means 50%. So that means that particular condition is following X-linked recessive pattern. But the exception here is that about the gender. Regarding X-linked conditions, usually the male inherits a Y chromosome to their son. So that means the pattern would be different if we talk about the male is affected, and since the female has two X chromosomes, then the pattern would be different, because mother can pass X chromosome to her son and as well as to the daughters. So that's why the inheritance pattern would be different when it comes to the X-linked disorders. So it is more common in males, because males only need one copy of the gene to be affected, while female needs two. Affected males are usually born to the carrier mothers. Why? Because the because the father cannot be passed. The father cannot pass the X chromosome to their son. So that's logical. Each male child of a heterozygous female, which is a carrier, has a 50% of chance of being affected, whilst each female child of a heterozygous female carrier has a 50% chance of being carrier. So that means if they ask about the mode of inheritance, then yes, you can implement your rule, that is 25% affected, 25% carrier, and 50% normal. But if they ask particularly about the gender, like how many son would be affected and how many daughters would be affected, then answer would be 50%. If you can see this diagram clearly, here we can see that unaffected son and unaffected daughter, carrier daughter and affected son. Out of these, if you just look at the sons, one is affected and one is unaffected. So there are 50% chance in males to be affected or 50% normal. And when we look at the female, she might be carrier for the condition or she might be unaffected. So here again, the chances would be 50-50%. Is everyone clear about the sex-linked recessive pattern of inheritance? If anyone have any confusion, you may ask me so that I can repeat. Okay, now let's move on to X-linked dominant. Since it's a dominant condition, it appears in every generation. Males and females can be affected, but females are more often and more frequently affected, which is opposite to the X-linked recessive. In X-linked recessive, the males are the main one who are going to be affected by this condition. But in X-linked dominant, since it's a dominant condition, so only one affected gene is enough to cause the illness. So affected fathers pass the trait to all their daughters, but not to sons. Why not to sons? Again, the answer is simple because now the father is going to pass Y genes or Y chromosome instead of X. So that's why there is no chance for a son to get a condition from his father in case of X-linked dominant. And since it's dominant, so one affected gene is enough to cause the condition. So the affected father pass a trait to all their daughters. Affected females can pass the trait to both sons and daughter. No carriers in X-linked dominant inheritance because anyone with the affected X allele express the trait. So this is as similar to autosomal dominant. So let's break down further. What if the father is affected or what if the mother is affected? So here is an example. If the affected father married to a normal mother, so what would be the pedigree analysis? Then definitely yes, since it's an autosomal dominant condition, so one allele is enough, and the father has just X chromosome, which he is supposed to pass on to the daughters. So yes, definitely 100% of daughters will be affected. When we talk about the sons, 100% of sons will be normal because they inherit the Y chromosome from the father. Is everyone clear about this point? And then next we have affected mother or a normal father. Now we just switch the scenario. Now the father is normal, but the mother is affected. And now imagine the mother is passing the X allele to which of her offspring. So each child has a 50% of chance of inheriting the affected X chromosome from the mother. Daughters, 50% chance to be affected and 50% chance to be normal. Son, 50% chance to be affected and 50% chance to be normal. So again, if they generally ask the question, the answer would be different. But yes, if they particularly ask about the gender, then you need to be more specific regarding your answer. So that's a tricky part. Autosomal dominant and recessive, they are way more easier as compared to the X-linked inheritance pattern. The reason is that sometimes if they ask general question, then yes, everything is fine, but you need to be extra careful and you need to pay some extra attention regarding the question. Are they asking in generally, or are they a bit more specific about the genders? Because that would decide your exact right answer. Okay, here's a question. Okay, let me tell you what I used to do or what are the tips to solve such SPAs. So always read the statements carefully. One thing you need to look at, are they talking about the mother or the father? The next thing you need to assess that about which condition they are talking about, because that would help you out to find the right answer in quickly. For instance, here they're talking about hemophilia. Now you have some background knowledge that what is hemophilia, what type of inheritance pattern it follows. So ultimately you will, and then suddenly you can recall the rule. If you remember that rule, then you are halfway there to get your answer. The next thing you need to pay attention to, are they asking about, again, the general question? Are they asking about the general pedigree, like how much percentage is going to be affected carrier or who is gonna be the normal? Or are they asking about a particular gender, like are they asking about the daughter or the son? That would change your answer a bit. So these are the things you need to consider. And again, please be very careful when you get questions from pedigree analysis, because if you missed a single word, then that would twist around your answer.
From pedigree, if they give, how to differentiate whether it is autosomal dominant or X-linked dominant?
Okay, I will give you answer once everyone give the answer to this question. Then I will show you the diagram and I will explain my answer. Okay, B is the right answer. It is X-linked recessive, and now the question is not generic. If they are asking in general, like what is the probability of the offsprings, like if they ask the other way around, like how many children would be affected or how many would be normal and how many would be carrier. So in that way, the answer would be different. But now they have added an extra point that what is the chance of a son to be inherit in hemophilia? So if in this question now they are gender specific for the son there are 50% chances to be to get the condition or 50% not. So B is the right answer here. Okay, so someone asked me a question like how do we know that is it X-linked dominant or it is autosomal dominant? Okay, one thing again in such questions they will give you the findings, like they will tell you like the mother is affected or the father is affected and now one child is normal or the other child is not normal. However, they will give you the findings and then you just need to put this formula on that and then you will easily get the answer. And the other way is that if you remember the condition's name and they have mentioned that condition, then that would also help you to find the answer. And classically, in case of autosomal dominant and X-linked dominant, you will see the difference between the condition on the father sides or on the mother side, and they will show you the pattern like how the condition is running on the female side as compared to the male side. However, autosomal dominant, they would not give you any scenario in which there is some any gender specificity. In this condition, both the males and the females you would see equally affected.
So only if gender specificity is there, it is X-linked. If not there, that is autosomal. Huh?
Yeah. In autosomal conditions, there is no gender specificity, but in X-linked, yes, there is.
That is the only differentiating point between both of them.
Yes, mainly. And be more specific, okay, there are many differentiating points. If you want to differentiate phenotypically between autosomal dominant and autosomal recessive, one classic difference is that in autosomal dominant there is structural abnormality, whereas in autosomal recessive there is some enzymatic or functional. The problem is at the molecular level or enzymatic level. And then on the if we go on the X-linked disorders, the main difference, you will see the pattern of inheritance classically from the father to the son side. Like for some conditions, like X-linked dominant, there is no chance for the sons to get the condition from the father side. So that would be given in the scenario, and you will get a clue for that for the X-linked dominant conditions. And for the X-linked recessive conditions, mainly they will give you the clue the son is affected. So classic difference between X-linked dominant is that the sons would be not being affected, But in case of X-linked recessive, the sons are the one who are going to be affected more, and mainly the males are going to be affected. For example, in case of Duchenne muscular dystrophy, it is mainly exhibited by the male babies instead of the female. So it is a classic condition of a male baby boy. So this is another difference. This is another clue you can differentiate. I think I should quote some extra examples, because if we have some scenarios in front of us, then it is way more easier to interpret. But what I do, this formula, I personally use these formulas if I found such questions in my exams. So I used to do this, and it is quite helpful for me. I hope it would be helpful for you. What I usually do, for example, if I get a scenario in which they have mentioned about that this percentage is affected or this percentage is not affected, I just add these percentages to those offsprings. Like if they are talking about that two kids are affected, then I will give them 50%. And according to that, I just fill these percentages, and I got my right answer. I recommend you to use this formula next time when you are solving these SPAs. So that in that way, you will better get these formulas. Okay, so should we move on to the next topic? Okay, let's start acid-base disorder. Okay, I have this topic is really extensive. So I have made some flashcards on respiratory alkalosis, acidosis, metabolic alkalosis, and acidosis. So do you want me to teach those flashcards first, or do you want me to teach how to interpret arterial blood gases?
Ma'am, how to interpret?
Okay, interpretation. I think I have that in my order. Okay, so one thing for arterial blood gases, usually we have many values on ABGs, but the most important one, what I usually do whenever I got a question to interpret arterial blood gases, what I usually do, I just quickly go and look at the pH level, because that is something which is very easy to interpret. So pH may be on the acid side, or maybe it may be alkaline. So this is the range. This is the normal pH of blood, which is 7.35 to 7.45. If your pH is less than 7.35, that means the blood is acidic. And if it is more than 7.45, that means the blood is on the alkaline side. So quickly, if you look at the pH, now, for example, the pH in your question is 7.25. That means it is acidosis. So now I know, I have the idea that I'm going to interpret something which is related to acidosis. So one job is done. Then second thing, now the next question is why this acidosis happen? Is it due to the problem? Is it the problem with the lungs, or is it the problem with the kidneys? However, for now, just look at the ranges. The normal range in the blood for carbon dioxide is 35 millimeter of mercury to 45 millimeter of mercury. If the range, if the value in the arterial blood gases is more than 45, that means the patient is having acidosis, or if it is less than 35, that means it is respiratory alkalosis. Next we look at bicarbonate. If the normal range is 22 to 26. If it is less than 22, that means there is some acidosis, or if it is more than 26, that means it is alkalosis. The partial pressure of oxygen it ranges from 80 to 100 millimeter of mercury. Okay, what is the significance of oxygen? It just tells us about the hypoxemia. So it has nothing to do with the acidosis or alkalosis. So we are left with just three things: the pH, partial pressure of carbon dioxide, and bicarbonate level. So these are the three steps. Identify if it is acidosis or alkalosis by looking at the pH. This is your first job you need to do. Uh, Once you know is it acidosis or alkalosis by knowing the normal ranges, then your next step would be identify if it is respiratory or metabolic. And how would you interpret that? By looking at carbon dioxide level and bicarbonate level. The carbon dioxide is mainly regulated by the lungs, and bicarbonate ion is mainly regulated by the kidneys. So any fluctuation with the carbon dioxide, that means something is wrong with the lungs. And if there is fluctuation with the bicarbonate ions, that means something is wrong, something is going wrong with the kidneys. So that would give you an idea of is it of respiratory cause or is it of metabolic cause. Once you know that, okay, once you know that, then the next job is it compensated or is it uncompensated? So I will show you in the coming slides, like how you can know is the compensation has been done or is it uncompensated. So again, if we look at these values, if any problem is going on here with the carbon dioxide level, that would give you an idea that it is acidosis or alkalosis of respiratory cause. Or if any problem is going here with the average or the basic value of the bicarbonate ion, that would give you an idea that this is of metabolic cause, and it comes from the kidneys and this comes from the lungs. So these are the three things you need to interpret from the ABCs. Okay, you can remember in kilopascals, especially for the carbon dioxide, and it is very easy. The range is, I think, from 4.5 kilopascals to 6 kilopascals. Okay, let's move on in the systematic way. The partial pressure of oxygen, I have already told you, it has not classically have to do something with the alkalosis or acidosis. However, the partial pressure of oxygen, it tells us about the patient that is our patient is having hypoxemia or not. So it is significant in that way. Okay, so the normal, if the partial pressure of oxygen is less than 10 kilopascals on air, that means your patient is hypoxic. And why this information is important, if you find that your patient is having this amount of oxygen in his or her blood, that means you need to give your patient immediately oxygen supply. If the partial pressure of oxygen is less than 8 on air, that means the patient is severely hypoxic and is in respiratory failure. So this is the significance of partial pressure of oxygen on arterial blood gases. Okay, hypoxia, yes, now we know, we interpret that our patient is having hypoxia, but why? And what are the relevant questions which are related to the partial pressure of oxygen? Like we can interpret that if the patient is having hypoxemia, there is respiratory failure. So what are the types of respiratory failure and how we can differentiate both on by just looking at the arterial blood gases. So type 1 respiratory failure, yes, partial pressure of oxygen is less than 8 and partial pressure of carbon dioxide is less than 6. Why that happens? Due to the ventilation perfusion mismatch. Volume of air, what does this means? The volume of air flowing to the lungs is not matched with the flow of blood to the lungs. Therefore, partial pressure of oxygen decreases and partial pressure of carbon dioxide increases. I just want to add extra. I just want to highlight a point, like how you can, in one word, in one line, how you can differentiate type 1 respiratory failure with the type 2 respiratory failure just to looking at your arterial blood gases, like how you can easily interpret the difference and how you can reach to your diagnosis. So the answer is, in type 1 respiratory failure, there is no a very high amount of carbon dioxide in patient's blood. But in type 2 respiratory failure, there is a massive accumulation of carbon dioxide in patient's blood. That means in your ABGs, partial pressure of oxygen would be less than 8. Along with that, the partial pressure of carbon dioxide would be drastically increases. Increased partial pressure of carbon dioxide triggers increased in ventilation, correcting the partial pressure of carbon dioxide, but do not for the oxygen due to different shape of the carbon dioxide and oxygen dissociation curve. So here, this is a summary, like partial pressure of oxygen would be less than 8 kilopascals with normocapnia. That means the partial pressure of carbon dioxide is less than 6 or 45 millimeter of mercury. So again, in one line, there would be hypoxemia, but with the normal range of carbon dioxide. So this is your type 1 respiratory failure. The causes of ventilation perfusion mismatch could be pulmonary edema, bronchoconstriction, or pulmonary embolism. In type 2 respiratory failure, now we have it is classically due to hypoventilation, which prevents the adequate oxygenation and carbon dioxide elimination. So now these are the patients who may present with the symptoms of hypercapnia, like they might have slurred speech, the flapping tremors, they might have flapping tremors. So what could be the causes for hypoventilation? There might be COPD, due to decreased compliance of lung tissues, chest wall, as in pneumonia, rib fractures, or in obesity, where the muscles are not able to have proper respiration due to the effect of obesity. Decreased strength of respiratory muscles, as in Guillain-Barré syndrome or motor neuron disease. Drugs which acts on respiratory center, they also, like opioids, they also depresses the respiratory center, and overall the patient may have hypoventilation, and due to hypoventilation the carbon dioxide is not able to eliminate from the body, or as a result of that there is hypercapnia. So again, in a nutshell, the difference between type 1 and type 2 is that in type 1 there is not hypercapnia, but in type 2, there is hypercapnia, and you can easily interpret your findings on the arterial blood gases. So we are done with the partial pressure for oxygen. Again, it has nothing to do with the metabolic acidosis or respiratory acidosis or alkalosis. Now let's move on to the pH. Again, if you're looking at the arterial blood gases and you are interpreting that, you need to look at pH to find out the first thing, is the patient is acidotic or alkalotic. Then consider what is driving this abnormality by moving through the next steps below. If the pH is normal, this may be as a result of compensated respiratory or metabolic acid hemostasis. Partial pressure of carbon dioxide at this point, prior to reading the carbon dioxide, prior to reading the carbon dioxide, you know the pH and the partial pressure of oxygen. So for example, you may know your patient's pH is abnormal, but you don't know yet the underlying cause. So it could be caused by respiratory system. And I have already explained you, you can look at the carbon dioxide level, just remember the ranges. If there is some fluctuation with the normal range of carbon dioxide, that means the cause of that acidosis or alkalosis is of respiratory origin. Or it could be metabolically driven by looking at the abnormal level of bicarbonate ions. So looking at the level of carbon dioxide quickly helps rule out the respiratory system as the cause of their derangement in the pH. So let's take an example from here. If we want to interpret respiratory alkalosis, yes, pH would be more on the would be increased. The carbon dioxide Carbon dioxide means acid. So that is lost. So definitely the patient may have alkalosis. And bicarbonate is normal. That means it has nothing to do with the metabolic cause. The classical problem in our patient is respiratory cause, and the patient is having respiratory alkalosis. Okay, in terms of metabolic compensation or the concept of compensation is that uh, if there is respiratory acidosis, for instance, is going on, the pH is decreased, carbon dioxide is increased. After a few days, the kidneys sense that there is something going on wrong. The body has a lot of amount of acid. So as a result of that, the kidney starts to compensate that acid. And how that happens? Uh, let's take an example of respiratory acidosis with metabolic compensation. So in acidosis, yes, pH would be decreased, carbon dioxide is increased. As a result of compensation, kidneys try to retain more and more bicarbonate ion, so bicarbonate level goes up. Since the are trying to compensate, so as a result of that, the pH is going to be going back to on the normal range, and that is your compensation. So if you're in your APG's interpretation, if the apart from the higher level of carbon dioxide, and you at the meantime you will see that there is increased level of bicarbonate ion, and the pH is more on the normal range, that would give you an idea that the kidneys are trying to compensate here. On the other hand, there is another concept of partial compensation. So what does that mean? Yes, carbon dioxide would be drastically high. At the same time, you will see the trend of increased bicarbonate ion, but still the pH is decreased. That means kidneys are trying to compensate, but the compensation is not enough to bring back the pH on the normal range. So we would label that as the partial compensation. So the in complete compensation, the pH would be more in the normal range, but in partial compensation, the pH is failed to come back on the normal range. Am I clear about this point? Okay. Bicarbonate ion, we now know the pH and whether the problem is metabolic and respiratory in nature from the carbon dioxide level. Piecing this information together with bicarbonate ion, we can complete the picture. And please tell me how many of you now are able to be at this point of interpretation. Please do let me know in the chat box like how you're going to approach your ABG's interpretation in a systematic way. Anyone who can tell me? Okay, I just want to make sure everyone is with me or not. Please tell me, by this time, are you able to differentiate between metabolic acidosis or respiratory acidosis or alkalosis? Like, are you able to pick this out? Is the interpretation I'm going to do, am I able to find out or differentiate, is it of metabolic origin or respiratory origin? Okay. Okay, bicarbonate word starts from B, so and base is also starts from B. So whenever bicarbonate, you will see the word bicarbonate, that means it is a base. And the logic is where this interpretation is quite logical if you relate this way. Like bicarbonate is a base. If the base is more, then definitely the patient may have alkalosis. If the bicarbonate, since it's a base and its level is low, that means bases are deficient in the blood. That means the patient may experience acidosis. When bicarbonate is low, the pH decreased as there are more free hydrogen ions, which leads to acidosis. The other terms you will see in the arterial blood gases interpretation is base excess. Sometimes they will give you this finding as well. So what is base excess? Base means our bicarbonate ion. That means this is the term which is used for the bicarbonate ions. Okay, Dr. Ambreen. I've already explained this very clearly. Like if you want to rule out, or if you want to find out, is it of respiratory origin? That means there is problem with the carbon dioxide value. And for that, you need to memorize the normal ranges. If you are not able to memorize the normal ranges, then it would be very difficult or nearly impossible for you to interpret ABGs. So this is your job. You need to memorize the normal ranges. And if there is a problem with the carbon dioxide level, that means this is of respiratory origin. And on the other hand, if there is some problem with the ranges of bicarbonate ion, that means the problem is metabolic. Okay, so base excess is another surrogate marker of metabolic acidosis or alkalosis. A high base excess, that means more than 2 millimole, indicates that there is a higher than normal amount of bicarb in the blood, which may be due to primary metabolic alkalosis or compensated respiratory acidosis. A low base, less than 2 millimole of per liter, indicates that there is a lower than normal amount of bicarb in the blood, suggesting either metabolic acidosis or compensated respiratory alkalosis. Then we have compensation. I already explained you, if there is a problem going on with the respiratory system, then kidneys tries to compensate. And if there is a problem with the kidneys, then lungs try to compensate. So respiratory acidosis or alkalosis, that means changes in the carbon dioxide level, can be metabolically compensated by increasing or decreasing level of bicarb in an attempt to move the pH closer to the normal range. For instance, if the patient have respiratory acidosis, that means there is an accumulation of carbon dioxide, and that means there is an accumulation of carbonic acid in the blood. So what does the kidneys do in compensation? It tries to increase the bicarbonate level, which is the base. So it tries to neutralize the increasing amount of acids by retaining more and more bases in the body. So this would be the kidneys compensation. In case of metabolic acidosis or alkalosis, changes in the bicarb can be compensated by respiratory system by retaining or blowing off carbon dioxide in an attempt to move the pH closer to the normal range. So here is the comparison. Okay, if you want to interpret that, is it compensation or not? For that, the values would be classically different. For example, in case of bicarb, we know the normal range, it is 22 to 26. If you want to see, is there any metabolic compensation is going on, then the bicarb level should be more than 26. That means in order to compensate, the level of bicarbonate should exceed its normal range. If that is still lying between 26 to 22, that means there is no more compensation. There is nothing compensation is going on. So again, for alkalosis, again, you need to look at the lower range, and same goes with the metabolic. If the level of carbon dioxide is less than 35, that means some compensation is going on, or it is more than 45. So in a nutshell, again, if you want to label that regarding the interpretation of arterial blood gases, that it is compensated or not, for that the values should be out of the normal ranges. That shouldn't be fall in the normal ranges. If they are in the normal range, then there is no compensation is going on. So the bicarbonate ions or carbon dioxide, they need to come out from their comfort zone if they want to provide an extra help to the other organ. Okay, I want to just recap the normal ranges. For pH, we have 7.35 to 7.45. For carbon dioxide, it is 35 to 45. An easy way to remember this, if you look at the pH, it is 7.35 to 45. And if you just take the 35 and 45, and now look at here, it is your normal range of carbon dioxide. So in that way, you can easily memorize the range of carbon dioxide. Then we have base excess, the bicarb level, which ranges from 22 to 26. And for oxygen, it ranges from 80 to 100 millimeter of mercury. Do we move on to the next topic? Okay, so I have made some flashcards for metabolic acidosis, alkalosis, respiratory acidosis, and alkalosis. And I have taken today's lecture from advanced life support, blood gas analysis, and pulse oximetry. Okay, so this is a flashcard for respiratory acidosis. Now we need, let's recap. Okay, what is respiratory acidosis? One thing, yes, there is an accumulation of acid. The blood is on the acidic side. Why we are talking, why we are saying that it is respiratory acidosis? Because the reason of that acid in the blood is due to carbon dioxide, because carbon dioxide means it's an acid. Why this happens? Due to inadequate ventilation leading to carbon dioxide retention. What would be your ABG interpretation? Acid means decreased pH and increased carbon dioxide. So this is the simplified version of interpretation of ABGs. What could be the causes for respiratory acidosis? We are saying that it is due to inadequate ventilation. As a result of that, there's a lot of carbon dioxide in the blood. Hypoventilation, yes. Increased resistance from airway obstruction, for example, COPD. Decreased compliance of lung tissue, pneumonia, rib fracture, obesity. Decreased strength of respiratory muscles, and some drugs like opioids, they causes respiratory acidosis. And here you can see this is the symptomatology. The patient may have muscle weakness, hyperreflexia, drowsiness, disorientation, rapid shallow respiration. BP could be reduced, dyspnea, headache, hyperkalemia, and dysarthrias. And here you can see the pH is less than 7.35 and the partial pressure of oxygen is more than 45 millimeter of mercury. And it is due to retention of carbon dioxide by lungs. Then we have respiratory alkalosis. So what does that mean? The acid is lost. That means there is less carbon dioxide in the blood. So alkalosis, the pH would be increased and carbon dioxide would be decreased. So simply, this is all about the presence of acid or the absence of acid. And what is your acid in terms of your arterial blood gases? We are taking acids from carbon dioxide. And from where we are taking the basic thing from the bicarbonate ions. Okay, how does this respiratory alkalosis happens? So since we know that if there is no carbon dioxide, there would be less acid, so there would be alkalosis. That means there are some conditions, those are the conditions which are going through which we are going to lose carbon dioxide that would lead to respiratory alkalosis. So the first thing is hyperventilation. And that's obvious. If we are having hyperventilation, we are washing out more and more carbon dioxide. As a result of that, in our blood, we are deficient with the carbonic acid, and we might have alkalosis. The causes are anxiety, panic attack, pain, pulmonary embolism, and pneumothorax. And this is the symptomatology. The patient may have deep, rapid breathing, hyperventilation, tachycardia, hypokalemia, seizures, lethargy, lightheadedness, nausea, and vomiting. And here in the lungs, you can see the pH is more than 7.45. That means it is on the alkalosis side. And when we look at the partial pressure of carbon dioxide, that is less than 35. So this is your respiratory alkalosis. Next, we have metabolic acidosis. It is maybe due to increased acid production or decreased acid excretion or increased rate of GI and renal bicarb loss. On arterial blood gases, yes, it is acidosis, so pH would be decreased. Since it is acidosis, that means we have less base in our blood, so bicarb would be decreased and base excess would be decreased. Okay, one extra point. When we talk about the metabolic acidosis, we further classify metabolic acidosis on the basis of anion gap. So anyone who have idea what is anion gap? Because I think there are some questions from anion gap. Do you have the concept like what we are talking about right now? If not, then I will move on for the explanation of anion gap. Okay, so basically what happens in our body, there are trillions of anions and cations. What are anions? Anions are the negatively charged particles or molecules, and cations are positively charged molecules. So let me tell you first what are cations and anions. Cations are positively charged, and in our plasma we have sodium, potassium, calcium, magnesium, and some positively charged proteins. So they are cations in our blood. Then we have anions, which are negatively charged, and the main ones are chloride, bicarbonate, phosphate ion, sulfate ion, and some negatively charged proteins like albumin. So normally these trillions of anions and cations, they float around in blood vessels. They live happily and stably. They just coexist happily together. Why is that so? Because plasma has to kept in electrically neutral position. So on daily basis, our blood, our plasma, it is electrically neutralized by these molecules. So what happens in anion gap? Basically, this is the calculation how many more cations we have in the plasma as compared to the anions. So that's why when we look at the formula of anion gap, we minus the negatively charged chloride plus bicarb from the cations. And the value as a result we get is our actual anion gap. For instance, the sodium, the level of the concentration of sodium in plasma is roughly 137 millimole per equivalent. And then if we look at the value of chloride, we have 104. And for bicarbonate, we already know that it is 24 milliequivalent per liter. Okay, now let's put here in the formula the value. We have for chloride 104 plus add in here 24. And collectively, then we minus it from the level of sodium, which is 137. And the result of that, we roughly have 9 value, which is our anion gap. And that value means 9 milli equivalent per liter means how many cations we have in more amount as compared to anions. Is everyone clear regarding the concept of anion gap, or do I need to add some extra points here? In simple words, we are just adding up the anions and just subtracting them from the cations. Okay, so the normal range, sometimes I think there is a question they ask about the normal range of anion gap. Like for how much range the anions should be in more amount than cations. The range is 3 milliequivalent per liter to 11 milliequivalent per liter. So this is the normal range. Anything below than 3, that means there are less anions. If anything, any value more than 11 or any condition which causing the anions to be more on the higher side, that is more than 11, that means there are more and more anions in the body. That means there are more negatively charged ions in the body as compared to positive ions. And initially, I have in the beginning, I have told you that in the plasma, in everyday life, the plasma is electrically stable. It is stabilized, and how it is stabilized by the equal amount of positive ions and the negative ions. So if anything happens on the anion side, that would cause the disequilibrium in the equation. Okay, in case of metabolic acidosis, we further classify on the basis of anion gap. Plasma neutrality dictates that the anions must be balanced cations to maintain a neutral charge. Therefore, sodium, which is the primary plasma cation, is balanced by the sum of the main anions like bicarb and chloride, which represent the anion gap. The reason why we have this equation, because we cannot exactly measure all the anions, so that's why we use this formula. Okay, in case of metabolic acidosis, what could be the symptoms of the patient? There could be rapid shallow breathing. The breathing pattern, which is classical for metabolic acidosis, is a cusmal respiration, and it is also known as the labor pattern breathing. There could be headache, decreased BP, hyperkalemia, muscle twitching, warm, flushed skin, nausea, vomiting, and diarrhea. And these are the symptoms which are usually exhibited by the patients of diabetic ketoacidosis. So what are the causes for high anion gap metabolic acidosis? That means that would be more than 11. So typically related to increased production or decreased renal excretion of hydrogen ions. The causes are diabetic ketoacidosis, lactic acidosis, aspirin overdose, renal failure. On the other hand, there are some conditions who do not disrupt classically the anions in the blood plasma. So there are some conditions who leads to metabolic acidosis, but the anion gap would be normal. So the conditions are gastrointestinal loss of bicarb, in diarrhea, ileostomy, or proximal colostomy, in renal tubular diseases, and Addison disease. Next, we have metabolic alkalosis. Again, it is since it is a alkalosis means there is more base in the blood. And since we are mentioning that it is metabolic, that means it has to do something with the kidneys. Okay, so due to decrease in hydrogen ion concentration or increase carbonate concentration, bicarb concentration. What would be your ABGs? Yes, alkalosis, increased pH. Bicarb, yes, there is increased amount of base, increased bicarb, and increased base excess. Causes GI loss of hydrogen ion, maybe in the vomiting. Renal loss of hydrogen ion, for example, if a person is taking loop diuretics and thiazide diuretics, that could lead to renal loss of hydrogen ions. Then we have iatrogenic, like excess alkali, such as milk alkali syndrome. What could be the symptoms? Confusion, restlessness, compensatory hypoventilation, severe vomiting, diuretics. These are the causes, or excessive bicarb. There could be hyperkalemia in metabolic alkalosis. So in metabolic acidosis, there is hyperkalemia. In metabolic alkalosis, there is hypokalemia. So this was all about the interpretation of arterial blood gases and what is metabolic alkalosis, acidosis, respiratory acidosis, and alkalosis. Okay, and I omit the topic vitamins from here because I personally believe that the topic regarding the vitamins deficiencies, that is quite simple and straightforward. So what I have decided to provide you with the flashcards of each vitamin. Okay, Dr. Ambreen, what point you want me to repeat? Do you want me to explain what is anion gap? Okay, so in order to understand the anion gap, you need to understand first what are anions and what are cations, what they are doing in the plasma and why they are so significant in the plasma. What is their normal purpose? Then we will go and look at the abnormal. So, so it's okay. Let me tell you the names of the cations. Cations means the positive charged molecules in the plasma. So we have majorly sodium, potassium, calcium, magnesium, and some positively charged protein molecules. On the other hand, we have anions which are negatively charged, mainly chloride, bicarbonate, phosphate, sulfate, and negatively charged proteins like albumin. So in the plasma, these anions and cations, they just stabilize the plasma by maintaining the electrical stability. So everything is in the right place, and that is needed to maintain the proper functioning and to maintain the pH of the body. So this is the significance. And why we measure the anion gap? Because it is not possible to measure all the anions in the blood. However, the major cation in the plasma is a sodium. So it is very easily calculated. The cations are easy to calculate, whereas anion are difficult to calculate. So that's why we used an equation just to take an estimate. Like if they, for example, if for sodium, the normal range is 137 milliequivalent per liter. That means there are if we want to maintain positive and negative charge in the body, they should, if the sodium is 137, then there should be equivalent amount of negative charge. So as a result of that, the body is stable, electrically stable, the plasma is electrically stable. Since we cannot calculate all the anions, so just we take the important ones, which is chloride and bicarb. The value for chloride in the plasma is 104, and for bicarb we take an average value of 24. We just add them up and minus from sodium. And as a result of that, we will get a value 9. So this 9 means these are the anion, the additional anions, which are there to maintain the electrical stability of the plasma, but we cannot measure them directly. So we are here calculating that indirectly. So that is your anion gap. And in terms of metabolic acidosis, why we are talking here? Because there are different causes, which some of the causes of acidosis, metabolic acidosis, they disturb this anion gap, and some of the causes do not. And here's the list. Like these conditions are the conditions which disrupts the anion gap. High anion gap means they are more negative charged. Okay, so we have example, we have diabetic ketoacidosis, lactic acidosis, aspirin overdose, and renal failure. And then we have causes of normal anion gap metabolic acidosis, which typically due to loss of bicarb, which subsequently replaced chloride in the plasma, resulting in normal overall anion concentration. Okay, and this is the reason why in these particular conditions, the anion gap is not disturbed because the kidneys retain more and more chloride in the blood, and also in these conditions the patient may have hyperchloremia. So chloride, since chloride is negatively charged ion, so it is an anion, so that's why the anion gap it wouldn't be disturbed. So that's why we label this as normal anion gap metabolic acidosis. And the main reason is GI loss of bicarb, as in diarrhea, renal tubular disease, specifically type 2 renal tubular disease, and Addison disease. Dr. Sangeeta, reading your question, pH is normal, carbon dioxide normal. Okay, it is a bit better if you share the exact values. The interpretation would be more easier if we have the exact values because we need to see the trend as well. Yeah, yes, please share me on the WhatsApp. Okay, I tried my best to make this topic simpler and easier for you. And yes, I was talking about the vitamins. I just omit that topic from the live session because I believe that is not very conceptual. It is more than like it's just like memorizing things and so what I was thinking to make some flashcards for each vitamin, so that by just reading a flashcard, you're good to go. You know what is that vitamin, what are the other names for that vitamin, and what are the conditions a person might have in the case of their deficiency, and what could be happen in case of overdose, and how we can easily pick this, how we can diagnose different conditions related to vitamin deficiencies. Okay, in terms of compensation, one thing uh, for compensation, like you need to know what is complete compensation and what is partial compensation. Another thing, what is the time when you are suspecting there is some compensation going on. So let me go back to the slide, this one. Okay, in order to interpret compensation, the values should be out of the normal ranges. For example, for bicarbonate ion, we know the range is 22 to 26. For the acidosis compensation or alkalosis compensation, the value should be more than 26 or less than 22. If the values are out of their normal ranges, that means now this is the time you can see that it is you may go with the option of compensation, and same goes with the carbon dioxide. If it is out of its normal range, that means there is some compensation going on. The other thing is that after you know that yes, there is some compensation, but the next question is it complete or partial compensation? For that, you need to look at the pH. If the pH is within the normal range or it is more closer to the normal range, that means it is complete compensation. But apart from these increased or decreased values out of the normal ranges, the pH is still drastically on the acidic side or the alkalotic side. That means it is partial compensation. Yes, for instance, for the compensation for the respiratory acidosis. In case of respiratory acidosis, the blood is having acid, and what can solve the problem? Some bases. So the base comes from the kidney's compensation, which is your bicarbonate ion. So in that case, the bicarbonate ion should be more than 26. If that is more than 26, that means there is metabolic compensation going on. But when you look at the pH, if that is near to the normal value or it is bringing back to the normal, that means it is complete compensation. But still, if it is not close to the normal value, that means it is partial compensation. However, the kidneys are trying their best to do. It depends on the scenario. Like for alkalosis, if alkalosis is of metabolic origin, that means the kidneys are having the problems is with the kidneys. There is more base in the blood. There is more and more bicarbonate ion. The patient is having metabolic alkalosis. So what would be the compensation here? The compensation would comes from the lungs. How that happen? The carbon dioxide should be go on the upper side so that we can increase some acid in the blood so that we can compensate with that base. So in that case, the carbon dioxide level should be more than 45 in order to compensate with the metabolic alkalosis. So this would be the compensation. Okay, so are we done with today's session?
ही होगा आधा घंटा दिन में पढ़ेंगे